Bismillah ar-Rahman ar-Rahim. Welcome everyone to the Cardiology T2T in collaboration with the Egyptian Society of Cardiology, Tunisian Society of Cardiology, and Yemeni Society of Cardiology. Here I have with me the esteemed professors, Dr. Osama Nounu from Yemen, Dr. Imtinan bin Murad from Tunisia, Dr. Ayman El-Hreish from Tunisia, and Dr. Hisham Saif from Egypt. Also, we have with us Dr. Azza Qatta, but she didn't make it to this meeting today. Our track is Bradycardia and heart block. We will start our today's session with Dr. Imtinan. She will talk about the sinus node disease. Let's start with her presentation.
Hello everyone. In the topic of bradycardia, I will speak about sinus node dysfunction. I will focus in ECG diagnosis. I'm Imtinan bin Murad, Associate Professor, Interventional Cardiologist and Electrophysiologist from Tunisia. As we know, the sinus node is located in the top right part of the right atrium, in the junction of superior vena cava and the right atrium. It acts as the natural pacemaker of the heart. The sinus node consists of two main groups of cells, the pacemaker cells, P cells, responsible for impulse generation, and the transitional cells, T cells, responsible for impulse propagation out into the right atrium. What is the sinus node dysfunction? Sinus node dysfunction is a disorder of the sinus arterial node caused either by failure of impulse generation by pacemaker cells or failure of appropriate impulse propagation by transitional cells or failure of physiologically appropriate response. When we regard pathophysiology, it's most the sinus node dysfunction is most commonly a disease of aging involving degenerative fibrosis of the conduction system, but sometimes sinus node dysfunction can be seen in younger, and this is mostly in the context of certain inherited or genetic condition. Sinus node dysfunction cover different clinical presentation like sinus bradycardia, sinus pulses, sinoatrial excite block, manifestation of tachycardia, bradycardia syndrome, and chronotropic incompetency. Regarding etiology, we must eliminate secondary cause at first, like iatrogenic ischemia, inflammatory disorder, infiltrative disorder, familial and congenital form of sinus node disease due to mutation in ion channel, metabolic disorder like hypothermia, hypoxia, spleen apnea is a reversible cause of sinus node dysfunction. When we eliminate all these causes, we can consider that the sinus node dysfunction is idiopathic. Regarding symptoms, patient with when sinus node dysfunction is mild, the patient are usually asymptomatic, but when the sinus node disease becomes more severe, patient may have fatigue, dizziness, confusion, fall, syncope because no electrical activity, no electrotemporization and contraction, leading to drop in blood pressure. Patient may have also angina, symptom of heart failure, and palpitation often seen in episode of supraventricular tachycardia. To make the diagnosis of sinus node dysfunction, we should make clear documentation of bradycardia correlation with patient symptoms. Let's start with sinus bradycardia. In sinus bradycardia, sinus node is still working, but show down in pacing the heart, so the heart rate of sinus node is below 60 beat per minute. The criteria for sinus bradycardia were persistent P wave with normal axis and morphology, because P wave originate from the sinoatrial node. The heart rate is less than 60 beat per minute, but regular with 1-to-1 AV relationship. It's important in clinical practice to differentiate physiologic sinus bradycardia seen in young people with higher vagus nerve tone, and other also in athletic patient due to effect from inappropriate sinus bradycardia. Another potential manifestation of sinus node dysfunction is sinus pause. This occurs when the sinus node is firing just fine and then suddenly stop pacing, leading to a dropped beat. For ECG criteria, the duration of the pause is more than the sum of two prior PP cycles, and the duration is at least 2 seconds. The length of sinus pause is the distance from the last P wave before the interval to the first appearing P wave in millisecond. We must measure the length of the sinus pause because we considered that sinus pause was clinically significant if the duration is more than 3 seconds, and we must differentiate sinus pause from non-contacted premature atrial contraction. In the case of premature atrial contraction, there is a P wave superimposed or after the T wave at the pause of different axis or morphology. On this rhythm trip, ECG, we see before the pause, we have a QRS preceding by a normal P wave. Then we have a pause more than 2 seconds. The pause is the duration of the pause is not an exactly multiple of PP interval. For sinoatrial excite block, the sinus node continue to depolarize normally, but block is due to failed propagation of pacemaker impulses beyond the sinoatrial node. The sinus node dysfunction in sinoatrial excite block can result from T cells fail to transmit the impulse, leading to sinoatrial excite block. The patterns of conduction in sinoatrial excite block are identical to the different type of EV block. However, at the initial sinus impulse is not visible on either ECG, the relationship between impulse generation and transmission must be inferred from the P wave alone. Only second, there is 3 degree of sinoatrial excite block, but only second degree sinoatrial block type 1 and 2 can be diagnosed from the 12-lead ECG surface. For the first degree sinoatrial excite block, there is a delay between impulse generation and transmission to the atrium. All impulses were transmitted to the atrium with just delay, so we have fixed conduction prolongation without a block. This abnormality is not detectable on the surface ECG. For the second degree type, some impulses were transmitted to the atrium and others are blockaded. For the type 1, there is a progressive lengthening of the interval between impulse generation and transmission, culminating in failure of transmission. we will have a progressive decrease of PP interval prior to the dropped P wave, and the pause is inferior to the sum of two prior PP interval, and the PP interval after the pause is greater than the PP interval just before it. This pattern is easily mistaken for sinus arrhythmia. For the second degree type 2, this pattern is equivalent of Mobitz 2. There is intermittent dropped P wave with a constant interval between the impulse generation and the atrial depolarization. So dropped beat wave without any preceding change in the PP interval, and the duration of the pause is equal, is an exact multiple of the preceding PP interval. And the PP interval after the pause is similar to PP interval just before it. There is an example of type 2 second degree sinoatrial block. The arrow, black arrow, is the P wave, dropped P wave. The blue arrow, the normal conducting P wave. We see the pause is 2.1 seconds, is exactly the double of prior PP interval. For the third degree of sinoatrial block, no of the sinus impulses are conducted to the right atrium. There is a complete absence of P wave. Rhythm may be maintained by junctional escape rim. The third degree of sinoatrial excited block is undistinguishable from sinus arrest due to pacemaker cell failure. It can only be diagnosed with the sinus node electrodynamic electrophysiological evaluation. There is an example of third degree of sinoatrial excited block. There is complete absence of P wave, and the rhythm was maintained by a junctional escape rhythm. For tachybradycardia syndrome is an alternating of between bradycardia with intermittent supraventricular arrhythmia, most frequently atrial arrhythmia. We can have a long pause when following the termination of the supraventricular arrhythmia. This condition is problematic. Why? Because for this patient, we cannot give rate controlling medication for the atrial fibrillation, atrial tachycardia. For chronotropic incompetence, the patient is unable to reach at least to achieve heart rate at least 80 of age predicted maximum rate in response to exercise. So the patient have symptoms associated with effort. The resting ECG is normal, and the diagnosis is made by treatment test. How to calculate age predicted maximum heart rate? The following 220 beat per minute minus age in years. Thank you.
Thank you very much, Dr. Amtinen, for this elegant, simple, and very clear presentation. From my side, I don't have any comment. Everything is clear. What about our prestigious professors?
Nice and interesting. Very clear. Thank you.
Thank you.
Dr. Ayman, you have any comments?
Nice presentation, Amtinen. I agree with you. It's clear. I think it's very clear. Thank you.
Dr. Amtinen, I realized that in European guidelines, they defined the sinus bradycardia at below 60 beat per minute, while the American guidelines put 50 beat per minute. What do you think?
I think 6 beat per minute is more appropriate for definition of sinus bradycardia.
Yeah, sure. But I mean that to be noted that there is some differences between the American and the European guidelines. Anyway, in my view, I can go a little bit below 60 beat per minute, as it is some kind of it is just sinus bradycardia, and we have many escape rhythms below. So it is not the last resort for the patient, the sinus. We have junctional, we have Hessian, we have infrahessian. So we have still reserve for the patient. So in my own opinion, it's better to go with the 50 beat per minute because of this. What do you think, Dr. Osama?
No, I have another comment. Maybe I agree. Many patients are having very asymptomatic bradycardia, reaching even 40. So I don't think that it is harm to reduce the heart rate, accepted heart rate less than 60. I have just a question, because I got a patient with sinus node dysfunction post cardiac surgery. I think due to the deviation of the circulation out of the heart during cannulation. Do you think the cannulation can cause this? Because my opinion, that patient, that is the cannulation, not the incision of the right atrium. I don't know.
You mean the superior vena cava cannulation? So there
yes,
is
they
mechanical
cannulate
trauma.
for yes, when they do tricuspid valve repair or replacement, and that patient got sinus node arrest, and went with an escape rhythm for the rest of his I don't know, for a long period he got junctional rhythm.
What do you think, Dr. Amtinan?
Did you face such case?
In my opinion, this kind of transient ischemia or transient trauma can occur during surgery, and that's why, in case of affection of the sinus rhythm, we can wait for about 6 weeks for the patient, give him chance for 6 weeks to recover before we give decision for pacemaker implantation, as this can happen due to ischemia, due to direct trauma, to any SA node, any bundles, which can recover with time, within 6 weeks. I think so. What do you think, Dr. Amtinan?
I agree with you.
Yeah.
I did not implant that patient. I waited for a long time. I returned back with the sinus rhythm, but I think it was the cannulation, not the direct incision injury, I think.
Yeah, it can happen. Very nice comment, Dr. Osama. And now, for the sake of time, we will go for the Dr. Osama presentation about the AV nodal block. We'll stop screen sharing for Dr. Amtinan, and we'll go for Dr. Osama.
First of all, I would like to thank the organizing committee of this scientific program, represented by the Egyptian Society of Cardiology, that give me this opportunity to share the colleagues, professors from Egypt, Tunisia, to present this program. My talk will be about AV nodal block, trying to share or to simplify the various types of AV block diagnosis. First of all, we'll talk about the block. Usually the block can involve any part of the conductive system, including suprahessian block, AV block, infrahessian, bundle branches block, both bundle blocks, proximally and distally, and left anterior and left posterior block. And the question raised here is, where is the escape rhythm is coming from? Usually it comes from the underneath blocked area. So the distal the block, the serious is the condition, because the escape rhythm will be unsatisfied and very slow. So our target here, or our goal for diagnosis, is the PR interval, and our cut-off point is 200 milliseconds. The PR interval more than 200 milliseconds, but with a P wave that can still conduct a QRS complex each time, it is a first degree block. Very simple, and this is the P wave with a PR interval more than 200 milliseconds, and so but can conduct the QRS complex each time. So it is a first degree EV block. On the other hand, when you see that there is some P waves are not conducted with a P wave and PR interval that is progressively increasing until a single P wave cannot conduct a QRS complex, this is MOBITS 1. So progressive PR prolongation till one P wave cannot be conducted to a QRS complex. This is MOBITS 1 in condition of acute coronary syndrome. Again, we have an progressive PR interval here, prolongation until one P wave cannot conduct a QRS complex. As you can see here, you can notice that this is the rhythm here is usually irregular. So irregular rhythm means it is a MOBITS, either MOBITS 1 or MOBITS 2. So here there is an irregular rhythm again with the drop wave. So we are dealing with either MOBITS 1 or MOBITS 2. But the question here, which P wave is conducting, which one is not conducting? To solve this problem, just you can plot a ladder diagram with plotting each P wave in an atrium and each QRS complex in an ventricle, and try to connect each P wave to its corresponding QRS complex. You can see here this P wave can conduct this QRS complex, and then this P wave usually the one that is conducting this QRS complex. So this P wave is presumed to be the blocked, and it is logic that this patient with AV block with a P wave attached to the QRS complex cannot be the one that conduct this QRS complex. If you just repeat, you will find it very logic and reproducible. So this P wave is the one that is not conducted. Again, it is MOBITS 1 with a progressive PR prolongation till drop of 1 beat. You can see here, on the other hand, there is some P waves are dropped suddenly without PR prolongation. So some beats are conducting, and then suddenly there is drop of P wave without PR prolongation. This is a MOBITS 1, MOBITS 2. So MOBITS 2 is a sudden drop of QRS complexes without PR prolongation, without progression of PR prolongation. You can see here that this is the PR interval is fixed, and then drop of QRS complex. So this is a MOBITS 2 again. So it is also an irregular rhythm. Here you can see that there is a regular rhythm, narrow complexes, and multiple P waves. Each P's and R's are running in their own rate and rhythm with complete dissociation. This is a third degree EV block. But the previous one was having a QRS complex that is narrow. On the other hand, this patient is having wide complex QRS complex. So it is this is an infrahessian complete EV block with a heart rate more or less 18 beats per minute, a female of 70 years, and was implanted pacemaker, and she's doing well. So this is another patient with AF and RR interval are fixed. So we are dealing with AF atrial fibrillation with complete AV block. On the other hand, we have another entity of patients who are having these P waves. We have two P waves and one QRS complex. We are dealing of 2-to-1 EV block with a QRS complex that is narrow, so it is suprahessian EV block. And there is no indication of pacing in these patients unless the patient is symptomatic. This is a lady of 50 years after AV nodal tachycardia ablation with a complicated EV block, and then implanted pacemaker. She came to me with infected pacemaker pocket, so I extracted the pacemaker and let her go home without pacing. She is having this narrow QRS complex suprahessian 2-to-1 EV block, asymptomatic totally. She's doing well for 2 years now without any complaint. So 2-to-1 EV block, suprahessian. On the other hand, we have here two beats with wide complex successively. So we have a 2-to-1 infrahessian EV block. This is an indication of pacing even in asymptomatic patients. Here, another entity of patients who are having no conduction at all until the end. We have a single QRS complex, a patient with 120 years old, presented with multiple episodes of syncope and implanted pacemaker. He is doing well now for 1 year. This is what we call an advanced EV block, as it is not a category of first or second or third or second 2-to-1 EV block. It is an advanced EV block. Again here, this is an atrial fibrillation with a slow rate. We have we call it slow AF, or AF with the low ventricular conduction. Here we have an atrial flutter after DVR, double valve replacement, intracuspid valve repair, and the advanced EV block with atrial flutter implanted pacemaker, and she is well advanced. And this is a form of advanced EV block. This is an ECG in the media was having some dilemma, and the students asked me to interpret it. I advised them to go retrogradely from the T wave. So each T wave should have a single QRS complex, that is this one. So the P wave is that one peaked. So we have 2-to-1 EV block with long QT interval and giant P wave in a patient with giant right atrium. So maybe you are dealing with Epstein anomaly, something like that. This is a patient was sent to me for a pacing, and actually we have a P wave that is different morphology, different PP interval. So we are dealing with non-conducted atrial trigeminy. So I give the patient instead antiarrhythmics, and he's doing well. Some are missing this as a pacing indication. This patient was in ER for 1 day till I came. He's having this P wave that is present in a couple of cycles here and then disappeared. This is what we call an accelerated junctional rhythm, or what we call it isorhythmic junctional rhythm. And this patient has no indication for pacing. This is not a block. This is an alternative rhythm, and has no indication for pacing. Thank you very much.
Thank you very much, Dr. Osama. Very, very nice collection of ECGs. And sorry. Okay. Very nice presentation, and I stressed before on the ladder diagram. I like ladder diagrams. I am teaching the young physicians, young cardiologists, the ladder diagram because I find it fascinating. Also, I like the ECG when you approached the analysis from the T wave, so that you can identify the QRS. So very nice presentation. Any of our professors have any comment or any question to Dr. Osama?
Very nice presentation and illustration by variety of ECG.
Yeah.
Thank you, Dr. Osama.
Dr. Ayman?
Nice presentation, Dr. Osama. Just in our practice, when we find we are interested in the weight of QRS when there is a complete EV block. So when their narrow is it's maybe or situated EV block. When QRS are wide, it's maybe besides Percuni, and so it's lower, it's lower, and it may be dangerous dangerous for our patient. So temporary stimulation is indicated to definitive stimulation. When we have one EV block, we are not sure it's a nodal block or an infranodal block. So there is in ECG some characteristic that can help us, like Pierre interval when he is huge is maybe a nodal block, when he is short is maybe infranodal block. Also, when we can give a patient atropine, when the block 2-1 is aggravated, is more, it's worse, worsen. So it may be an infranodal block. What is it is ameliorated by atropine? Maybe it's a nodal one. And also when we do the vagal maneuver, so when we aggravate the block, it may be a nodal block, and when we don't no effect in our block, maybe an infranodal block. So maybe for student, it's interesting to do the difference between nodal and infranodal in the 2-1 EV block, because isoprel we use in our practice to accelerate frequency and heart rate maybe worsen an infranodal EV block to one EV block.
Yes, thank you very much for this comment. Actually, if it is distal Hess block or proximal suprahessian or distal suprahessian, it can be differentiated also by stress ECG or by even Holter ECG, and even minimal symptoms of the patient. If it is just some fatigue, something like that, we implant a pacemaker. And that patient post EV nodal tachycardia ablation complications, and then pacemaker infected. The patient was afraid, and she went home because she refused the pacemaker. Actually, I told her, if once you got very minimal symptoms, you should be implanted, but she refused the implantation. Thank you very much for the comment.
And thank you, Dr. Ayman. That was very illustrative, the difference between supra and infrahessian in 2-to-1 block. Very nice. Only one question to Dr. Osama. What about if we have a patient with a sinus rhythm of 120 and he start developing first or second, whenever second or first degree heart block, that can be considered as a heart block or EV nodal block?
Well, it is a functional, so the AV node function is like this. Some patients is exaggerated. Some patients the AV node can conduct all the beats and should not be considered as AV block. Sometimes the patient, if he is an old, can tolerate this rhythm, but many times young patients cannot tolerate, and the indication of pacing can be discussed with the patient.
Very nice. So to diagnose heart block, the sinus rate should be at least below 100.
Yes.
Yeah. Thank you very much. So now we will proceed for my own presentation. It will be about indications for pacing. First, for in cases of acute presentation, with the patient acute presentation, and final diagnosis for implantation of a permanent pacemaker. We'll go for the presentation. Esteemed member of T2T group, president, coordinator, distinguished professors, and all participants. I hope this gathering proves both enriching and enjoyable. I would like to extend a special welcome to our esteemed professors from Tunisia and Yemen, whose presence has not only enriched our group, but also broadened the horizon of our teaching. Your contributions are invaluable, and we look forward to learning from your expertise. As we embark on this presentation, let us foster an environment of collaboration, open-mindedness, and mutual respect. May this experience be fruitful for all involved, hoping the best for our young generations, the hope of the future. My talk will outline the delicate balance between when to pace and when not to pace. But I would like to begin with an intriguing story from Solana, Sweden in 1956. In this city resided Arne Larsson, a 41-year-old engineer with his young wife Elsa Marie. While on a vacation, Arne consumed tamed oysters, leading him to contract hepatitis. Over the following 2 years, his condition progressively deteriorated, eventually manifesting multiple fainting attacks daily. He received the diagnosis of Stokes-Adams attacks resulting from heart block, a condition deemed lethal with no prospect of recovery. His frightened young wife understood that Swedish heart surgeon X. Senning dedicated himself to finding a treatment for her husband's condition, but without success. Meanwhile, Senning collaborated with electrical engineer Ron Almquist on developing a device capable of electrically stimulating the heart. Utilizing the recently invented transistors, the desperate young wife insistently sought Senning assistance day and night, pleading for help for her dying husband. Eventually, Dr. Senning consented to perform surgery on Larsson. Regrettably, the pacemaker only sustained the heart's rhythm for 5 hours before ceasing to function. Several hours later, engineers devised an enhanced version of the device, which proved successful. Larsson was discharged from hospital after 2 weeks, and a few months later, an improved version of the device was implanted to him. Subsequently, Larsson enjoyed normal life for the next 43 years. He underwent 26 device replacements during his lifetime and passed away in 2001 at the age of 86 due to metastatic melanoma. Larsson was the first human in history to implant a pacemaker. His story stands as an emblem of how technology has the power to save lives. Since its invention, the number of pacemaker implantation worldwide has seen an exponential increase, rising from fewer than 50,000 in 1970 to over 350,000 in 2021. We now have a question and a concept to consider. The question: why do we implant pacemakers in the first place? The answer is, first, to save the patient's life and to prevent injury, even if the patient is asymptomatic. Second, to save others' life if the patient's job is involved in public safety. Lastly, to improve the symptoms and facilitate recovery of the functional capacity, allowing the patients to return to their normal life and job. The concept is to minimize pacemaker implantation, and if implantation is necessary, minimize pacing as much as possible. The best favor we can do for a patient with bradycardia is to avoid implanting a pacemaker if it can be avoided. One of the most crucial steps in treating patients with bradycardia and heart block is proper management upon presentation. Young physicians are at the forefront of this critical task. Let's walk through the correct steps for approaching a patient presenting with bradycardia and heart block in the emergency department. We begin with a patient arriving at the emergency department, where we discover that significant bradycardia is likely the cause of his problem. The first step is to take the necessary time to evaluate the patient's hemodynamic condition by assessing their vital signs, also conducting a thorough and efficient history and physical examination, focusing on the cause of the condition, its complication, and any associations. A clear 12-lead ECG is indispensable, as it may be the key for diagnosis. The patient may never again have an ECG similar to the one taken during the initial presentation. Initial treatment in the emergency room, if you suspect the cause, may be due to drug or chemical ingestion, poisoning, or even Lyme disease, as the time in this situation is critical. If you don't find any immediate actions to be taken in the ER and the patient is stable, transfer the patient to intensive care until monitoring and continuous evaluation will start, without the need to implant transvenous pacemaker. If the patient is unstable, start by administering atropine, except in cases of heart transplantation, as atropine, of course, will not work on a denervated heart. The initial dose of atropine is 0.5 to 1 milligram, which can be repeated every 3 to 5 minutes up to a maximum dose of 3 milligrams. After administering atropine, if there is a confirmed evidence that the patient's condition is caused by drug toxicity, most commonly from calcium channel blockers, beta blockers, or digoxin, proceed with the appropriate antidote for each. In this case, calcium channel blocker overdose, administer either calcium chloride or calcium gluconate. If these are not available, you can start with an insulin bolus and infusion. For beta blockers overdose, administer glucagon, 3 to 10 milligrams, and infuse from 3 to 5 milligrams per hour. If glucagon is not available, start an insulin bolus and infusion. But be careful to monitor serum glucose and potassium levels. If digoxin toxicity is suspected, administer digoxin, fat fragments, and correct potassium levels as needed. If the patient continues to have symptomatic bradycardia and heart block, and the specific drug antidote do not improve their condition, and if the patient is severely symptomatic and hemodynamically unstable, proceed with temporary pacing. If the symptoms are mild to moderate and the patient is hemodynamically stable, and the patient also experiencing an acute myocardial infarction, you can administer an intravenous bolus of aminophylline 250 milligrams. If the patient is not in acute myocardial infarction, you can start a beta agonist infusion with dopamine, isoproterenol, or epinephrine at the shown doses. If the current measures remains ineffective, temporary pacing is an option to consider. It is crucial to note that temporary pacing should be approached cautiously, as it carries numerous complications that could potentially endanger the patient's life. Therefore, it is typically considered as the last resort rather than the first-line intervention. Concerning the varieties of temporary pacemaker, there are three types. One, transvenous pacemaker employ a bipolar electrodes inserted through the jugular, femoral, or subclavian veins, delivering pacing to the right ventricle. Number two, transcutaneous pacemaker, which are typically found in the emergency response vehicles and ICUs integrated in the DC machines for immediate use in case of unavailability of the transvenous pacemaker. Number three is the externalized active fixation pacemakers, which are utilized for long-term temporary pacing, particularly in instances of infection or temporary contraindications for permanent pacemaker implantation. Here are the recommendations of temporary pacemaker implantation in sinus node disease based on the 2018 ACC guidelines. Here we can read from the last row of the table, quote, in patients with sinus node dysfunction with minimal and or infrequent symptoms without hemodynamic compromise, temporary, transcutaneous, or transvenous pacing should not be performed, end of quote. In the recommendations concerning temporary pacing for atrioventricular nodal block, there are no class 3 recommendations observed. However, it is noted that temporary pacemaker implantation is recommended for patients experiencing symptoms or exhibiting hemodynamic compromise. This underscores the importance of pacing intervention for individuals with significant clinical manifestations or compromised hemodynamics, not for stable patients. Now, let's transition to the second part of our discussion, focusing on the indications for permanent pacemaker implantation. However, we have identified four primary indications. First, sinus node dysfunction, AV node block, bundle branch block, and reflex syncope. The streamline of our review process will start by assessing the most critical factor first. Then we will prioritize contraindications or class 3 recommendation. Following this, we will delve into the regular indications based on their significance. And finally, we will address any exceptions within each indication category. This structured approach will ensure comprehensive coverage and clarity in our assessment of each indication. In sinus node dysfunction, the most important factor indicating pacing is symptoms. And the pacing is contraindicated in two conditions. First, if the cause is reversible. Second, if there is no symptoms whatever, even if the ECG showing sinus node dysfunction. The first regular indication, if there is symptoms suggesting bradycardia, is correlated by any ECG phenomena indicating sinus node disease. If there is no correlation, the level of evidence is demoted from class 1B to class 2B. The second regular indication is the presence of symptomatic Brady-Tachy syndrome, in which pharmacological treatment of tachycardia will participate in symptomatic bradycardia. Another alternative to this is to treat the tachycardia with ablation. In patients with symptomatic sinus node dysfunction during AF or immediately following cardioversion, AF ablation, not pacing, is indicated to treat sinus node disease. The first exception in patients who have history of syncope, and we was not able to correlate it with any ECG phenomena, although during Holter recording he has asymptomatic pauses of more than 6 seconds. The second exception, that if the patient is symptomatic with an ECG showing sinus node dysfunction, and there is a strong correlation between both the symptoms and ECG, this condition occurred after cardiac surgery, we should wait for at least 6 weeks for possibility of spontaneous recovery before offering permanent pacemaker. The third exception is similar to the previous one, but the cause is cardiac transplantation rather than cardiac surgery. Also, we should wait for 6 weeks for possible recovery. The third exception, that we can implant a pacemaker to asymptomatic patient in case he has a complex congenital heart disease and his daytime heart rate is less than 40 beats per minute, or he has pauses more than 3 seconds in ECG. The second category are patients with AV block. Here, the most important factor in judging the necessity for pacemaker implantation is the ECG, not the symptoms, as the presence of these ECG features can put the patient under high risk of sudden cardiac death, even if he is asymptomatic. These ECG features include second-degree Mobitz type 1, 2-to-1 block, and more advanced 3-to-1 or more blocks, and finally, complete AV block. This ECG feature indicates pacing even if it wasn't permanent, as long as the cause of these changes is not completely curable. The only contraindication in this category is the presence of completely reversible and curable cause. Remember, the absence of symptoms is not a contraindication like in sinus node disease. The first regular indication is the presence of ECG features we talked about in patients with sinus rhythm. The second, in patients with previous ECG features and atrial fibrillation. You can see here that the sinus and AF have the same indication class. The first exception is patient with second-degree heart block Mobitz type 1, if symptomatic, and if there is a strong correlation between the symptoms and the ECG. If we couldn't find a correlation and an EP study was conducted and showed an intra or infranodal block, a pacemaker can be implanted to this group of patients. Observe the patient must be symptomatic. What about patients with first-degree heart block? Believe it or not, you can still implant a DDD pacemaker to those patients if they has a PR interval long enough to cause the atria and the ventricles to contract at the same time. Thus, the atria will contract against closed AV valve, inducing symptoms that occur in patients with pacemaker syndrome. The third and fourth exceptions are in patients after either a acute myocardial infarction or cardiac surgery and fulfilling the criteria for pacing. In this category, we have to wait at least for 5 days before implanting a pacemaker for hope of spontaneous recovery. The fifth exception is in patients after TAVI who has the indication for pacing after the procedure, but we can wait for 24 hours to 48 hours for hope of spontaneous recovery. The sixth exception is in patients with congenital complete heart block who are known for stable, higher escape rhythm with no symptoms. In those patients, any of the following indicate pacemaker insertion. First, the developing of symptoms, then wide escape rhythm, if there is long QT due to slow rate, if there is complex ectopic beats, which can be induced by bradycardia, or a daytime heart rate less than 50 per minute, or long pauses more than triple of the escape cycle length. Some authorities argue that all patients with congenital complete heart block needs pacing, but with class 2B indication. The seventh exception is the patient diagnosed with myotonic dystrophy with PR or QRS prolongation or any second-degree heart block. These patients are under very high risk of rapid progression of heart block and sudden cardiac death. Thus, with the slightest sign of conduction disturbance, pacemaker should be indicated. In patient diagnosed with myopathy and lamina gene mutation, if there is a PR prolongation or left bundle branch block, not only pacemaker is indicated, but an ICD is indicated. Same as in patient with sarcoidosis, if indicated for pacing, an ICD should be implanted. As in both conditions, system produce both lethal brady and tachyarrhythmias. The last exception is similar to the previous two, in which patients with Kern-Sire syndrome, a disease caused by affection of the mitochondrial DNA involving the eye, skeletal muscles, CNS, endocrine system, and the heart conducting system, inducing myopathy and heart block. The third category is patients with bundle branch block in ECG. Most important factor in these patients is the occurrence of syncope as a sign of occurrence of more advanced heart block. In this group of patients, the correlation between the occurrence of heart block and symptoms cannot be established, and the presence of bundle branch block is taken as a sign of a potential disease in the conduction system, which cannot be recorded. The symptoms is essential in these patients, which differentiate them from patients with slow or absent conduction on one of the three bundle branches without complete absence of conduction from the atria to the ventricle. Thus, the pacing is contraindicated in asymptomatic patients. The first regular indication is syncope as symptom and at least bifascicular block in the ECG plus an EP study showing signs of his disease. The second is like the first, but here we will not take the patient to the EP lab, and we will depend on the patient clinical status. He should be old, frail with recurrent syncope, but here the indication is demoted from to class 2B instead class 1B if we use the EP study as the previous indication. The only exception here is for patients with right bundle branch block who underwent TAVI and developed any other conduction disturbance after the procedure. We should implant a pacemaker immediately, or we can wait for 24 hours before implanting the pacemaker. The fourth and the last category is the reflex syncope group. The most important factor in this group is to register a cardio-inhibitory type of reflex syncope, which involves significant reduction of heart rate, significant sinus pulses, or heart block associated with reproduction of symptoms without initial drop in the blood pressure. That response could be recorded during head-up tilt table test, or during carotid sinus massage test, or Holter recording, or during pharmacological testing using adenosine. The contraindication of pacing under this condition is the lack of the documentation of cardio-inhibitory syncope. That means clinical suspicion is not enough. The first regular indication is cardio-inhibitory syncope proved by tilt table test, Holter, or carotid sinus massage in patients older than 40 years with severe recurrent syncope with no prodroma to warn the patient to take abortive measures. Here, DDD pacemaker with rate drop response is indicated, and this is the only class 1A indication in all pacing indications. The second regular indication is patient with adenosine-sensitive syncope documented through pharmacologic testing using adenosine injection in patients with high clinical suspicion and negative or non-diagnostic tilt table test. In this patient, a DDD pacemaker with a rate drop response is indicated as class 2B. As we conclude our presentation, we have covered the management of bradycardia patients in the emergency department, including indications for temporary and permanent pacing. In case of bradycardia and heart block, I look forward to future discussions on this topic. Until then, may your endeavor be distinguished, and I extend my sincerest gratitude for your valuable time and attention. Thank you. Thank you, and thank you for your patience. I know it's a little complicated and a little bit long. Any comment from our esteemed professors?
For me, very nice presentation with all cases of indication for pacing. It's very clear, and I have no comment. No comment. Very nice.
Thank you, Dr. Antonin. Okay. Dr. Ayman?
Nice
Dr. Osama?
Dr. Ayman, go ahead. Go ahead, Dr. Ayman.
Nice presentation, Dr. Hisham. It's a very nice presentation and very clear. Maybe I am thinking about a question. I let Dr. Osama give her opinion, and then I am preparing one question for you.
It's okay.
Okay.
Dr. Osama?
Thank you, Dr. Hisham. A very nice presentation and comprehensive concepts and fascinating illustrations. And I have a comment and a question. The comment is about the infections causing the block. Actually, I got 3 patients. We don't have Lyme disease or Chagas disease or so, but I got 3 patients 3 years ago. There was an epidemic of diphtheria, so I got 3 patients with the complete heart block, and one patient. I waited for 1 month.
Yeah.
I implanted one patient. Another patient recovered after 1 month, and the third patient escaped without pacing. She refused implantation and left the hospital against medical advice. So I don't know if you have such cases in your country. The question is the de-escalation of pauses in the guidelines. The American reaches even 5 seconds of pauses as an indication of pacing. Actually, I'm afraid I still with the cutoff of 3 seconds pauses. I don't know what is your local implementation of this indication of pacing. Thank you.
Thank you, Dr. Osama. First, in my years of practice, I didn't see any patient who needs pacemaker implantation for sinus pauses alone. Actually, I didn't. But in my opinion, to diagnose sick sinus syndrome, you need at least 3 seconds. So any patient who is symptomatic caught with 3 second or more pauses, we should implant a pacemaker as long as the cause is non-reversible. By non-reversible, I mean that there is no operation, there is no MI, there is nothing. We can wait for recovery. The second situation, if the patient is having syncope and we cannot catch anything, we did everything for this patient, tilt-table test, carotid sinus massage, adenosine injection, Holter, several times, and we didn't see anything and still have syncope. And once in a Holter, we catch a pause of 6 seconds or more. Even if the patient didn't report any symptoms, we should implant a pacemaker in this case. This is my opinion, but actually I didn't face this situation clinically. But that's what I'm going to implement if I saw a patient in this situation.
What is the longest pause you faced in your practice? Because I faced one patient in Italy with 27 seconds, and one patient in my country 18 seconds, and she was treated as epilepsy, unfortunately, for years.
You are lucky, Dr. Osama, to see such things. In my practice, what I saw, patients maybe during the pacemaker implantation, during our implantation, and I think the patient wasn't on. I don't remember whether the patient during EP study or during pacemaker implantation, the patient had a pause of like 15 seconds and he didn't have any problem, as if the patient is used to this kind of bradycardia. The patient didn't have any symptoms with like 15 seconds pause.
And
Yeah.
My question is ready, Dr. Hisham. My question is ready. I want to know your opinion about innovation and new technology in pacing, leadless pacemaker, and left branch stimulation. There is, you think? There is an indication in our practice and in our countries.
Sure, Dr. Ayman. Every day there is an innovation in pacing. At first, I was interested, a few years ago, I was interested in stem cell treatment for the patients with heart block. But the stem cells, even for patient with myocardial infarction and heart block, didn't go well. There was some complications, there was some problems. So I didn't go this way, but I think if we can go this way by treating patients with stem cell therapy, it will be very good still. If there is any hope, I will go with such a research. The other thing is the leadless pacemaker. Leadless pacemaker for sure has an indication. One of the first indication, the patients with pockets, the patient with infected pockets, the patient who cannot find a pocket for him, patient with multiple infection, and we have multiple patients like this. Also, patients with very difficult access. If we don't have access, like venous access, we have maybe every like 6 months, we have a patient like this with maybe very tortuous veins. So we cannot implant a pacemaker for in patient like this. So either we refer him for surgery for epicardial lead implantation, or we refer him for leadless pacemaker, which is still very expensive and not widely available in Egypt. Also, nowadays, I have many of my colleagues in European countries like UK. They started using the dual chamber leadless pacemaker. So it has an indication for them, maybe for patients like with congenital heart disease, and they also don't have direct access, direct connection between the atrium and ventricle and so on. So it has its own complication, yes, but this technology still not available in our countries.
Okay. Thank you very much.
Thank you, Dr. Ayman. So without further delay, I think we are late now, so we will start with the presentation, very nice presentation for Dr. Ayman about pacemaker follow-up and pacemaker programming. Yes.
I have done only follow-up, Dr. Hisham.
Yes.
I have done only follow-up.
What?
I have done only follow-up of device, but not programmation.
Yeah, okay, follow up. Because the scope of our audience is not the programming. Yes, right?
Okay.
This is not the scope. This is not our scope. We are not talking to EP fellows or EP specialists. Okay, so
Absolutely.
we'll start with the presentation now. Actually, it's very nice presentation.
I am Ayman El Harish. I am electrophysiologist from Tunisia. In the next 10 minutes, I will talk you about device follow-up. We start with the frequency of follow-up after implantation and hospital discharge. Is recommended to do the device interrogation 2 week between 2 and 12 weeks. Then every 6 months for ICT and CRT, and every 12 months for single and dual chamber. If there are signs of battery depletion, we must interrogate the device every 3 and 6 months. Device follow-up or interrogation doesn't mean cardiac disease follow-up. We can follow-up of the underlying cardiac disease should not be overlooked. The goals of follow-up is to ensure patient safety, to provide physiological pacing, to improve patient clinical management, and to maximize device longevity. For practice, use following steps: wound check, clinical history, technical check, and optimization of programming. For wound check, we must verify the wound healing quality. For the absence of hematoma, we look for possible skin adherence. For clinical history, we look for symptoms like dizziness, like loss of consciousness, palpitation, phrenic stimulation, increase in shortness of breath, and fluid retention. The objective of technical check step was to determine the battery voltage, to verify the device ability to operate, and estimate the remaining longevity. To check the lead impedance, to verify that lead are electrically intact, because the lead impedance can warn you of lead solution and failure or lead conductor fracture. To test capture threshold, to verify an appropriate safety margin, multiply the amplitude threshold at least by 2. To test sensing threshold, to verify an appropriate sensing safety margin, and to observe the underlying rhythm. And finally, the last step is to optimize programmation by adjusting pacing output, so we can improve device longevity. By checking arrhythmia, we can use stored EGM, the accuracy of arrhythmia diagnosis, and to determine the patient atrial arrhythmia burden. By reducing the percentage of unnecessary pacing, by managing EV delay and activate algorithm to provide physiological pacing, adjust asservissement, accelerometer, or ventilation minute, and for ICD to verify if tachycardia discrimination algorithm work properly. Finally, education and counseling is mandatory to ensure the ongoing health and well-being of patients with their device. Thank you for your attention.
Thank you very much, Dr. Ayman, for this concise and very informative presentation. Actually, we start with Dr. Imtinan. Do you have any comments, any questions?
No comment, no question for Ayman.
Very short.
Very nice, Ayman. Very short, very precise presentation.
Yes. Yes, I agree. Dr. Osama?
Yeah, thank you, Dr. Ayman. Precise and just focused on point. Very nice presentation. My question, always I have this this problem about patients who are ischemic, who are having this LV lead anteriorly. How to optimize this this CRT goal or aim for resynchronization? Your troubleshooting.
In my opinion, Dr. Osama, the implantation procedure of left ventricular lead, coronary science lead, is mandatory to put it in the right vein, and we prefer to the lateral and medium lateral vein to have a good response to resynchronization therapy. So in my practice, I avoid to put the leads in the anterior part of the sinus coronary science. So if I can't put the leads in the right position in the lateral vein or medium lateral vein, I report a procedure to prepare more support and technical support to do it the next time. So I think we can try to ameliorate duration between right ventricular stimulation, timing between right ventricular stimulation and left ventricular stimulation. But what we put is the anterior part of our heart. I think it may be difficult to have a good QRS and a narrow QRS as a good response for therapy resynchronization. Dr. Hisham, what you think about this question? It's my opinion, and in my practice, I do that, but I don't know what you do in your practice.
Yes, I think your approach is very good, Dr. Ayman, but one of the things we are using to optimize the CRT is tissue Doppler. We can check with the tissue Doppler first before we go to the cath lab the area which we prefer to pace or to find the vein in this precise area. If we couldn't find, we put the lead in the nearest of them. So, Dr. Osama, sometimes when you go even in regular patients, you will not find a good vein.
Yes.
Right?
Sometimes you have only
sometimes it
vein.
happens. Yeah, sometimes it happens. That's why we can resort to other things like left bundle area pacing. Your question before, left bundle area pacing be a solution for that. And that the response or the responders in ischemic patients is less than response in patient with dilated cardiomyopathy. So this is unacceptable. Anyway, this question is way beyond or it's outside outside the scope of even in the guidelines. We have like when to implant a CRT or when to implant an ICD, and this is not the scope of bradycardia anyway, but we like to hear from experts. Thank you for the question, Dr. Osama, and thank you for the answer. My question for Dr. Ayman is a little bit for the side of the young generations. So what's the importance for the young cardiologist to have, or for the anesthesiologist to have a permanent magnet with him in the OR or the ICU? What it can benefit for the patient with a patient with a pacemaker or an ICD?
Thank you, Dr. Hisham, for this question. It's for young cardiologists who don't do device follow-up with a programmer. I think it may be interesting to do to see the magnetic response of when you put an element on the battery and show the rhythm and the frequency of stimulation that maybe tell us about the battery longevity and and battery it maybe give us some signs of battery of battery to battery replacement. But I think, in my opinion, when you do that cardiologist maybe maybe they can't maybe oublier. Must remember. Forget. Cardiologist may forget to address a patient for rhythmolog for electrophysiologist to do device follow-up, and so it may be dangerous for our patient. You know, it's important to see longevity of battery, but it's more important to see impedance of leads and to see threshold of stimulation and detection to adjust programmation of our device. Maybe when you tell us to do systematically this application in our practice, patient maybe don't have a good follow-up for their device. So I think it's important to the message for our cardiologist: when a patient have a device, it must be interrogated by electrophysiologist at least one per year, and so he can see the magnetic response. But I think the most important that the device follow-up is done by electrophysiologist by a programmer. Another thing, maybe for in procedure, when you use electric bisturi, it can be interesting to applicate the imant. So for patient who are stimulo dependent, so we can avoid over detection, and we can avoid we can avoid pause and the auriculoventricular block for stimulo-dependent patient. Excuse me, I try to explain, but I think
it's okay, Dr. Ayman. We wanted to note for our audience that both Dr. Ayman and Dr. Imtinan is having French as the first language in their medicine and in their usual daily practice, and it's a very great effort from their side to deliver this. We are taught in English, and it's usual for us, but it's not the case for Dr. Ayman and Dr. Imtinan. So thank you.
Thank you.
Thank you.
Both Dr. Imtinan and Dr. Ayman for your time and for it's late now, and we hope to be with us today. Hope to see here in the other stages of this educational I want to thank the professors, Dr. Imtinan bin Murad and Dr. Ayman. Session and third phases of this educational event.
Thank you very much.
It's a pleasure for us
Thank you very much.
to work together.
Thank you very much.
Very nice experience.
Yes. Thank you, Dr. Osama.
Thank you very much, everybody. Hoping to gather again another occasion.
Inshallah.
Inshallah.
Good night.
Good night.